So I'm going to talk on acute heart failure in hospital management. Basically, previous speaker was supposed to speak on the diagnosis and re-evaluation. So few slides I will be probably go ahead. So as per Sir Lewis has said, the very essence of cardiovascular medicine is the recognition of early heart failure. That is the key in managing the heart failure. So I will be discussing this topic in different outline, that is diagnosing clinical risk evaluation, decongestion stabilization, planning for discharge after the GDMT. So the description heart failure was existed from ancient Egypt, Greece and India. Previously, the bloodletting and leeches were also used for the centuries. If you see the evolution of heart failure management from 1980s onward, every decade there is addition of some new drug, and since last 2010, there is a real invention and real management as far as mortality benefit started from the sacubitril/valsartan trial, that is paradigm HF, and then subsequently SGLT2 inhibitors, which came as a big therapy in 2020. In the natural history, if you can see, at least 80% of heart failures are hospitalized once, and 40% of them gets hospitalized 4 times after heart failure diagnosis. That's how it is a natural history in a disease. Mortality after first hospitalization is at 1 month about 10%, which increases by every 10% up to at 5 years is around 40%. There are different definitions depending on which guideline. This is about the ESC. Most of the talk is from ESC guideline from 2021. So as for stages, the ACC1, the at risk is stage A, pre-heart failure, and advanced heart failure. Classification by EF, that we know that HFrEF, H and HFpEF. Basically, you need to know this because hemodynamically it is important to know, and that's how the management will be different in the different stages. So I simplified. Whenever the patient comes to us with the symptoms, he already had the start of the disease in maybe about 1 month duration when he was euvolemic, and then now coming to the clinical congestion as a symptoms when you see that patient. So in hospital, at admission, what are the important things of screening and evaluation in the emergency department? Then the next step is decongestion and stabilization. Subsequently, inpatient care involving the multispeciality depending on the clinical status of the patient, and the laboratory test. Then at the same time, guideline directed medical therapy should be started after the stabilization, and you need to plan a discharge, planning how the patient is going to be there once you get discharged. So having a clinical typical symptoms of heart failure, when you see in any ED or OPD, you do the basic tests, ECG, echo, pulse oximetry, X-ray, in few cases lung ultrasound if required, and the laboratory tests. Basic laboratory tests are usual like KFT, liver function test, and then the natriuretic peptide testing. So whenever the BNP or NT-proBNP is less than 300 picogram, the acute heart failure is less likely. That is most important. So you can rule out the other problems if the BNP is normal. In initial evaluation of acute heart failure, you should remember 7 P's depending on the phenotypes, precipitants, polymorbidity. These are all the risk factors for acute heart failure which are combined together. As far as hemodynamic classification in the 7, like cardiogenic shock, acute pulmonary edema, congestive heart failure, these are different phenotypes. In end organ manifestation, you need to evaluate. Most of the patient can have the renal component, that is cardiorenal syndrome in about 1/5 of the patient. Gastrointestinal involvement maybe in about 20 to 30% patient. Respiratory involvement, you get sleep distorted breathing in 50% of the cases, while neurologically cognitive impairment is common in 25 to 50%. So these are the cases. This is also a risk factor in number of cases. After initial assessment, a proper clinical examination and laboratory test, there are different scoring systems which are essentially at the practically level. They are not that essential, but in the different scoring system that like EHM-ARG score and ADED score, which predicts the 7-day mortality and 1-month mortality, definitely depends on the criteria which I showed you, the 7 P's. So after clinical congestion scoring, you can assess by how is losing the weight, what are the biomarkers and the outcome wise. The main criteria for ICU admissions same: hypoxic patient, tachycardia, tachypneic or hypotensive, and any evidence of hypoperfusion. Hemodynamically, by Forrester classification, this was based for acute MI only first, but nowadays you can use even for the heart failure patient, most commonly in that warm weight, that the pulmonary congestion is there, so up to 50% is the commonest one. Depending on that, you can add diuretic, vasodilator, or consider ultrafiltration if resistant to diuretic. Another is a warm dry, you can adjust the oral therapy in those patients. These are the stable patient as such. Then cold weight is the third common. Coming to when you see the patient in a casualty or ED, if the patient is hypotensive requiring or having a respiratory failure, if it is AS, then he may go for the stabilization by inotropic agent, ventilatory support or mechanical circulatory support. If it's not there, then you rule out this precipitating factor like ACS as etiology, hypertension, arrhythmias, pulmonary embolism, infection, and if it is there, particular treatment. That should be done as in the immediate phase in the ED department. Coming to decongestion, diuretics remain the cornerstones of therapy. You should also restrict the sodium in those patients. Remember, door to furosemide time is most important, up to 180 minutes. If you start the diuretic therapy, it has shown maximum mortality benefit. Otherwise, later on the mortality is high. How to manage the diuretics? If the patient is not on any oral diuretic, de novo patient coming to you can give more than 20 to 40 mg IV loop diuretics. You can see the response after 2 hours by making urinary spot sodium. If it is more than 50 to 70 milliequivalent, that means he is responding. And also the urine output around 100 to 150 ml per hour after 6 hours, that's a good sign. If he is not, repeat the dose again. Do it the same levels, and if it is not, then combination diuretic therapy can be given. That kind of, if you may have that clinically diuretic resistance, and those patients can be added as you can add another thiazide diuretic like a metolazone or acetazolamide. Monitoring and defining trajectories means regular assessment of the clinical status on daily rounds in the ICU, laboratory test and progress has to be done. Escalation or a de-escalation depending on how he is responding to the diuretic therapy, depending on urine output and sodium levels. Also using biomarkers, are they going up or down? Monitoring patient weight, intake and output closely. Introduction of novel therapies in refractory cases like acetazolamide. This is the advertire which has shown in addition to loop diuretics, the acetazolamide has shown benefits as far as greater incidence of successful decongestion in that trial. Initiation and up-titration of guideline-directed therapy. This is the important hemodynamic mechanisms of different drugs. We will see in different presentation throughout the day. So, comparing HFrEF and APEP management, you can see after this loop diuretics are the common, then you can after stabilization oral diuretics, after the stabilization blocker, MRA and SGLT2 inhibitors. While in APEP, beta blockers are not there, but you use the beta blocker in the patient who has atrial fibrillation and uncontrolled rate. Those patients will also have a beta blocker therapy. Now suppose the patient, most of our patient also has a kidney problem, and those patients have a CKD event. So this is the recent consensus by ESC came last April, I guess, this April. And you can see that MRA and RNA are not to be given if the eGFR is less than 30. So clear definition and clear guideline as such. So if eGFR is less than 15, monotherapy, mostly a beta blocker, ISD or tolerated ACE therapy. Tips to facilitate effective HFrEF therapy. If the creatinine goes less than 20% from the baseline, do not usually require dose reduction. But if it is more than that, you can. If potassium is more than 5.5, no other evidence of any arrhythmias on ECG, you can still wait or give a potassium binders. If the patient is hypotensive at present, suppose coming in the OPD or some first follow, discontinuation of drugs should be avoided. First you check the response by supine position and standing position. Also see other signs of whether he is symptomatic for hypotension. So accordingly, this should be managed. Apart from these 4 major therapeutic agents, we have different agent. If the patient is presenting with atrial fibrillation, anticoagulants can be added. If sinus rhythm, tachycardia more than 70, ivabradine can be added. Congestion, different agents. Then the iron therapy in the patient whose if ferritin is less than 100 or the T saturation is less than 20% in those patients can be given. These are important trials. Everybody knows these trials as far as RNA is concerned. Then in the preserved ejection fraction, the another trial, a Paragon HF, which has shown the effect. Then we have MPure study, which with the empagliflozin in the preserved ejection fraction has shown, in the reduced ejection fraction has shown the good results. This is recently published study. So accordingly the presentation, having the loop diuretic therapy if the congestion is relieved, increase the diuretic doses if not, medical therapy optimization, and then depending on if there is a hypoperfusion or organ damage, depending on, you can give the vasopressors, mechanical circulatory support, patient may require renal replacement therapy later on. I think device therapy is a bigger talk. Someone else in Dr. I think Shah will confirm with that. He may take that talk. So just an outline, if the ejection fraction is less than 35% and KRS less than 130 millisecond, where appropriate, and symptomatic VTR if class 1 indication in ischemia is in ischemic as ICD. Class 2A is a non-ischemic for ICD. For CRT, LBBB morphology, symptomatic, less than 35%. Yes, it is a class 1 in those cases, as far as CRT is concerned. Recommendation which I think I have gone through. And during the same phase, you should also plan a discharge. A separate talk is there for a discharge. Device therapy, usually after the discharge, you should optimize all the pillars by 12 weeks and then reassess the patient for device therapy. If still symptomatic on this therapy, then you can consider for the device therapy. Cardiac transplant, heart transplant, selected advanced heart failure patient despite being on OMT and device therapy who cannot be discharged without that. No other therapeutic option except LVAD as a bridge to transplant. So thank you very much.